Hello, everyone. Thank you so much for joining our webinar. We are waiting just a couple of seconds to have everybody joining the Zoom link. And we're going to start. My name is Alejandro. I'm the marketing manager Promedon. And it's a pleasure for me to be opening this webinar with this panel of experts. We have had more than 450 registrations, which is a lot. People from all over the world wanting to listen to these professionals. So to complete it, I just wanted to say thank you to the panel and open the word to Martin.
Thank you so much, Alejandro. And I'd just like to thank you and your colleagues from Promedon for your generosity in supporting this endeavor today. I'm Marty Koyle. I'm professor of surgery and former chief of pediatric urology at the Hospital for Sick Children in Toronto. I'm very privileged to have not only colleagues, but friends of now 4 decades with Professor Puri and 2 to 3 decades with Nicola and Boris. And we've inspired and learned from one another for the thing that really conceived pediatric urology, and that was vesicoureteral reflux. So we're going to try to spend the next hour or so with each of our experts delivering 1 lecture, after which we'll try to answer as many questions as possible in the time allotted to us. The way you will give me questions that I can relate to the panelists is via the Q&A at the bottom of your screens. So raising your hand will not be useful. We can't answer things verbally. And likewise, the chat box will not be utilized. So again, at the bottom of your screen, you should say something that says Q&A with 2 emojis imposed upon one another, which is the question and the answer. So I'm going to introduce each speaker as they speak. We'll start with Professor Puri, who really is the dean of injection therapy. We wouldn't be here today without the contributions he's made with his inventing the sting, and he deserves all the credit for it. He certainly had more experience than anybody in the world in this. He continues to be active in both pediatric surgery and pediatric urology, and he's currently the Newman Clinical Research Professor at the University College Dublin. So we'll start with you, Prem, and I'll introduce Drs. Chertin and Capozza as they each speak. So go ahead, Prem.
Well, first of all, let me thank Promedon for inviting me to speak at this important meeting, and I look forward to sharing our work with you here, as well as also discussing various aspects with Marty, Nicola, and Boris. I was asked to talk about the fundamentals of endoscopic treatment of vesicoureteral reflux. As all of you know, this is the most common urological problem in children. You know, if we took out vesicoureteral reflux out of the work of nephrologists or pediatric urologists, they will have very much less work to do. It is recognized as a major cause of chronic renal failure. This is a UK renal registry report which documents the prevalence of end-stage renal disease, and you'll see that a quarter of patients who had dialysis or transplantation, the cause of this was reflux or renal dysplasia. Similarly, 1/3 of patients with hypertension, the cause was renal scarring. And also parenchymal renal injury or renal scarring occurs early in children. This is a study from our own institution where 549 consecutive infants and 86% of these presented with a first febrile urinary tract infection. And if you look at here, a quarter of these patients, even in infancy, showed evidence of renal parenchymal damage on DMSA scan. And what is worrying is about half of them was scarring was moderate to severe. This is another study from our institution, 774 children with high-grade reflux, grade 4 and 5. Again, you will see here, 37% of these children showed evidence of renal scarring. And like the last study, half of them showed moderate or severe scarring. And the most important predictors of renal scarring in these patients were the grade 5 VUR children over the age of 1 year and those with bladder bowel dysfunction. The three most important mechanisms for the causation of reflux are the reflux of infected urine causing interstitial inflammation, damage, or high-grade sterile reflux causing damage as a result of mechanical factors, and then renal dysplasia, which is a developmental defect. I mean, certainly most of us will agree that the first two categories, if you can treat the reflux early, you can prevent renal damage. But even in renal dysplasia, if you can treat them early, you can prevent progression of renal damage in these patients. There's been, all of us would know that there's been a lot of confusion created by this, the AAP guidelines for the diagnosis and management of urinary tract infection. These are the revised but coming to the various options which are available currently for the treatment of primary VUR. You can give continuous antibiotic prophylaxis, or you can give intermittent prophylaxis, which I'll get a urinary tract infection, or bladder training, or a combination of all these three: antibiotics, anticholinergic, and bladder training. You can do an open reimplantation of ureter, or laparoscopic or robotic reimplantation, and finally endoscopic treatment. Well, we started treating patients with vesicoureteral reflux endoscopically in 1984, following successful experimental work in the piglets. And I think that it's a fairly simple technique, but the single most important factor which determines the success or failure of the procedure is where you place your needle. Since I developed the technique, I have always injected very superficially, just under the mucosa. It has two advantages. Firstly, you use less amount of volumes, and also it produces a nice, I mean, in the end, the most important thing is that you should have a nipple-like effect. And if you get this type of effect, you know that you have stopped the reflux. And patients who have grade 4 or 5 reflux where the orifice is golf hole, I tend to insert the needle inside the ureteral orifice, but always towards, not too far from the lower margin of the ureter. As you can see the bulge appearing inside. And and I must say that in my cases, I've rarely injected more than 1 ml of tissue augmenting substance. And again, your whole thing is that you want to get a nipple-like effect like this. And once you have that, you know that you've stopped the reflux. A lot of people worry about the obstruction, and that was my biggest worry when I was doing the experimental work. But the compliance of the ureter is so much that obstruction itself is extremely rare. In fact, a research fellow of mine, Friedmarker, did a meta-analysis, systematic review, which we published a year ago in Current Urological Reports. And about 1% of patients get a obstruction, but there is no difference. We didn't find any difference in relation to the tissue augmenting substance or technique, whether it's a HIT technique or, again, I have always maintained still doing this sting type of procedure, as you can see here. And when I say, wide orifice like this, as I mentioned earlier, I tend to inject inside the ureter orifice, but always not too far off. But the advantage of this is that not only you are producing a nice hump, but also you are lifting the tunnel, or in other words, elongating the tunnel. Again, I mean, the whole idea is to get a nice again, another example, and you'll see, I still use my flexible needle. I mean, this is more than 30 years ago, which was developed and is made by Storz. I find it easily to manipulate, especially I'm a great believer in just going through the single hole. I don't like to make multiple punctures. And the advantage with this flexible needle is that you can twist it. If the mound is appearing to one side, as you'll see from the next example, I show you in this, if you find that the mound is appearing to laterally or more medially, you can rotate the needle and place it in the exactly place where you want it. You see it here. You can see it appearing more medially, but by rotating it, you can have the ideal place where you want it, as you will see here. So let me show you our results. The 1,551 consecutive children, again, right from the beginning, we have only treated grade 3 to 5 refluxes, and this is over 2,300 ureters. And that shows you the results or the grading of reflux. Again, as I said, we only had a very small percentage of grade 2, and they were treated either they had renal scarring or recurrent febrile infection. This shows you the results. I must say, over the years, that's the first injection overall, including all grades, our results have been in the region of between around 87%. With the first injection, we have done a VCU repeated 3 months, and an ultrasound then every year, and then every 2 years. For the last 2 years, I'm not doing a VCU post-operatively. We only do it if the child has a recurrent febrile urinary tract infections. As I said, I haven't had obstructions. We had a dilatation of the pelvic glacial system temporarily, which resolved, but not. I haven't had to operate on these patients. Now, there are two fundamental reasons for treating reflux. One is to prevent renal scarring. The other is to prevent febrile urinary tract infections. And therefore, we looked at our 1,271 consecutive children who had been successfully treated for psychoureteral reflux. As you'll see, 96% of them had grade 3 to 5. And we published this study. Nearly 6% of our patients develop febrile urinary tract infections after the successive over a long period, anything from 3 months to 9 years after the, and we did a follow-up VCUG in 34 patients who had 2 or more febrile urinary tract infections, and we found recurrence in 4, neocontralateral VUR in 3, and 23 of them had voiding dysfunction. The interesting finding here was all 23 were girls. There are still a lot of controversial issues in relation to endoscopic management. you know, there's still people talk about not treating grade 4 or 5 endoscopically. We have been treating these patients right from the beginning, grade 4 and 5. This is our experience of 851 consecutive children with grade 4 and 5. As you can see, 1/3 of these patients had evidence of renal scarring at the time of injection. This shows you the grading of reflux. 90% had grade 4, 10% had grade 5. And that shows you the resolution. In high grade 4, 5, our first injection results have been around 70%. And some of them needed a second or third injection. Again, what about duplex ureters, and especially complete duplex? Is again, many people still feel that this is an indication for surgery. We have injected a complete duplex system for many, many years. And most important thing is I tend to inject under the common sheath. And this is our experience. We published, we can see 123 consecutive children with complete duplex system, and half of them had renal scarring at the time of injection. And this shows you the results. Or sorry, results. This slide shows the result. About 70% we were able to stop the reflux after a single injection in a complete duplex system. What about VUR in infants? There's a lot of controversy because, as many of us know, that VUR resolves in many infants spontaneously, but at the same time, infants, especially male infants, have high-grade reflux, and also infants are the most vulnerable patients to develop renal damage, and therefore, because of this simple, minimally invasive procedure, it makes sense to treat these patients, and which we have been doing it. And this is our results in 276 consecutive infants. And the vast majority had grade 3 to 5 reflux. And that shows you the result. We were able to stop the reflux in these infants after a single injection in 80% of the ureters. This is another study from Spain, same kind of results. What about neocontralateral VUR? Many centers, especially in America, have been doing prophylactic injection on the contralateral side. We looked at our patient at 662 unilaterally successfully treated ureters, and we found that only 10% of them showed evidence of a contralateral reflux. But what was interesting, half of them are only grade 1 and 2, needing no treatment. And therefore, we certainly do not recommend injecting prophylactically in unilateral reflux. What is the current focus of our research at the present time? I am going to briefly share with you. One is genetics of VUR, because for many years we have been doing screening, and now we have the largest cohort of siblings in the world from one city. As you can see, it's 605 siblings with a prevalence of 42%. And our siblings are quite unique because we had siblings who presented with urinary tract infections, and then there were siblings who were screened. And so we were able to compare this. And in my opinion, this is of our sibling study. This is a very important slide. And you can see the incidence of renal damage or renal cortical abnormalities was exactly the same in index patients and siblings with urinary tract infections, whereas it was significantly lower in patients who, or siblings who never had a urinary tract infection. So naturally, because we have large number of siblings, we have, for many years, we have been involved in genetic studies, and we have contributed, we have done a number of genome scan and found some important regions of interest, especially in chromosome 2 and 22 and 1q. And this is just shows you the last 2 years we have published some important papers in relation to genetics in New England Journal and Nature Science reports, as well as Nature Genetics. And I strongly believe now from my work in genetics that we are not going to find a single gene for VUR. I think that there are going to be different genes for patients who develop reflux nephropathy from those who do not reflux nephropathy. We have already seen that for instance, the incidence of duplex system in our male siblings was 15% compared to mixed or female, where it was only 5%. So I think it's quite a heterogeneous. What about the other thing I've been interested for the last many years is the diagnosis of VCG, because as you know, the VCG is quite a traumatic procedure for the diagnosis, not only for the child, but also for the parents. And many nephrologists or pediatricians do not send patients for this investigation because of this reason, but being trauma to the child. So for many years, I've been, for the last nearly since 2013, I've been involved in finding a non-invasive test for, which could replace VCG. I mean, we are nearly there. And as I said, the reason is requires ureteral catheterization, traumatic and pain for both for the patient and the parent, and radiation exposure. So we have developed a medical device based on electrical impedance tomography. This is our work of this device in the animal piglets, where we were able to diagnose unilateral reflux with successfully in 95% of the patients and of the piglets. And our device picks up anything more than 5 mil increase in the volume of the kidney. And this is the belt that we have developed. We have already done 3 clinical trials in India and 1 in New York. And in these clinical trials, we found that there was a lot of, there was a substantial background noise, especially when the child cries and all. So a few months ago, we were successful in obtaining a €2 million grant from the Horizon 2020 EU grant to take care of this noise, background noise. And we are hoping that we will be able to, so we have, by the way, this device is patented in all parts of the world now. And we are hoping that we will get rid of this noise, and hopefully this will become available for the clinical. And we are planning a multi-center trial for this. So let me summarize what I've said. As a result of our direct result of our research, this 50 minutes and outpatient procedure radically altered the management of VUR throughout the world. Endoscopic subureteral injection is an excellent first line of treatment in the management of all grades, high-grade VUR. This outpatient is safe and can be easily repeated in failure. At least you need to give one chance. Even people who are not very fond of this, you at least need to give one chance to the patient. If it's a grade 3, 4, you have a chance of more than 80% stopping the reflux with a single injection. It's highly effective in high-grade VUR in infants, and it makes sense to treat these patients because they are the most vulnerable group of patients to renal damage. Long-term follow-up is very important, and I've been very fortunate in following these patients. I mean, last week I saw a 36 years old mother whom I'd done a Teflon injection in 1986, and she had 3 children, and that's come to see me because one of the children had high-grade reflux. So that's the. Thank you very much, Marty, for the opportunity. Thank you.
I really appreciate it, Prem. Thank you so much, as always. To keep things going, again, I want to remind the participants that no questions will be answered in the chat box. If you're going to pose a question, please do so in the Q&A icon emoji at the bottom of your screen, to the far right of your screen. So I'd like to now introduce a good friend and one of the most beautiful skiers I've ever seen in my life, Professor Nicola Capozza, who's now the head at Bambino Gesù Hospital in the Vatican. It's the Pope's hospital, by the way. And he's certainly as prolific as anybody, having used many of the current materials available for injection therapy. And he's going to discuss the utilization of injection therapy for obstructive UVJ obstruction and complex cases. Go ahead, Nicola. Thank you.
Thank you, Martin. Thank you for your nice presentation. Thanks a lot to Promedon for this opportunity to discuss about endoscopic treatment of VUR. Again, I'm going to present some particular issues regarding our experience with 2 different materials. And at the end, I'm going to discuss a little about some complex cases that can be treated with endoscopic treatment. Okay, these are the materials we used in the past, and the reasons why we stopped using Teflon are well known. Not so clear are the reasons why we stopped bovine collagen, and the main reason is this: the volume reduction. Despite the cross-linkage, bovine collagen shows a significant volume reduction. And as we verified in this experimental study we performed years ago in a pig model. And that's why we looked for a better material. And in 1995, we started with REFLUX. And by the way, I am proud to have contributed to the FDA approval in 2001. And the results were very, very good, especially in the last part of our series. And they even improved when we introduced some technical variation called the URI, but I'm going to talk about it later. So that's why do we decide to change material. The results were good. The main reason was the long-term results, and as you can see in this slide, the rate of failure after endoscopic treatment with REFLUX was quite high. The best series, as you can see, is the Chertin series. It's about 4%, but we go up to 26% of failure at long-term follow-up. And that's why we tried other material like Vantris, and we started to compare characteristic of the extranomer compared to Vantris. And talking about easiness of injection, Vantris showed was very easy to be injected at the same like REFLUX. And about the durability, Vantris is supposed to be a biodegradable material, but you know that it's not true, not because just the outer part of the implant is biodegraded, and the inner part probably lasts for forever, maybe, but at least for many years. And there is no doubt that a material like Vantris that is non-biodegradable gives us the best guarantee of durability. About the risk of migration, Vantris is safe thanks to the large size of the particles. We and also in experimental studies, the migration has never been observed. But the most interesting aspect, in my opinion, is the deformability. And Vantris is the lowest deformability in comparing with the other materials. And you can see in this slide, this is an ultrasound performed 6 months after the treatment, and the implant keeps a very nice round shape. And now let's talk about some technical aspects. In addition to the standard sting as described by Puri, there are other modifications like the intraureteral injection, with or without hydrodistension. And then there is the modification I proposed in 2012 called URI, that is ureteral repositioning and injection. This is the description of the standard procedure. And now I'm going to present the technical modification called URI. And you see here the insertion of the needle is like in the standard procedure, just few millimeters under the meatus. And now with the tip of the needle, we try to catch the ureter, the distal part of the ureter, and we perform this maneuver, this lifting maneuver, trying to attract the distal part of the ureter into the bladder. And then we inject the material. You see a very high bulge using a very small amount of material. In a while you will see the syringe, and I have injected just 0.3 milliliters. And this is some details, a drawing showing details of the technique with the needle, the lifting maneuver. And with this maneuver, you have a length increase of the submucosal tunnel, and maybe a welding effect like Marty suggested me many years ago. And this is the animated illustration of the technique. Insertion of the needle. With the tip of the needle, you attract the ureter inside the bladder and then inject. And now another problem. It's the amount of material that relates to both efficacy and safety of the material. And years ago, the answer to the question, how much to inject, was very easy. I used to say as much as necessary to get the right configuration, the nipple or the volcanoli configuration with the ureteral orifice on the top. But it was soon clear that especially changing the Vulcan agent, we had to change also the injection volume and maybe the technique, as these Turkish authors try to demonstrate. And if you see here, you see these are the results of this study. And they used a very low amount of material compared to reflux, and they had the high success rate with Vantres compared to deflux. And this is interesting to notice that over the year, they used less and less material. You see here, they started with 0.8, and then in 2014, just 26.26 milliliters without any negative effect on the success rate. That was always very good. So this confirmed what I used to say years ago, that if you perform the treatment in a correct way, that means very superficial in the true submucosal space, not too deep, the more you increase your experience, less material you need. And now let's talk a bit about the complication, the secondary obstruction after endoscopic treatment, like in this case, or in this. And in the last years, there was maybe a greater attention to this problem of the obstruction problem. At the same time, the Vantres is widespread. There was a very big diffusion of Vantres. That's why many of us thought that the problem was the material, the bulky material, and there are some studies. One was performed by Chertin, and we participated in this study, trying to identify the risk factors for obstruction. This is another paper by Puri. And finally, again, Kokerov and Chertin, they state that the obstruction not related to the type of tissue augmenting substance. I mean, in our study, we tried maybe the only significant risk factor was the pre-existing obstruction that is a wrong indication to endoscopic treatment. In other words, a refluxing obstructive megaureter, that it's similar to grade 5 reflux. But don't forget that the true secondary obstruction exists. And this is a case with obstruction, with late obstruction of the ureter. And we went to the pre-treatment VCUG, and we found this, that there is the so-called big sign, that means, and also the contrast medium at the end of the micturition inside the ureter. So in these cases, endoscopic treatment shouldn't be done. Okay, but this is another case. In the left side was grade 2, and this is the pylography after the obstruction. You see, there is no doubt it's an obstruction, and the grade of reflux was just grade 2. So maybe we couldn't say these are the conclusions, but at least we identified some risk factors. One is the pre-existing refluxing obstructive megaureter, but also the inflamed bladder mucosa at the time of the procedure. We suspect the intraureteral injection is a risk factor, and also we try not to exceed the volume of 0.5 milliliters. And so our suggestions are these: the selection patients at the treatment stage, avoid intraureteral injection at the time of the treatment, volume less than 0.5 milliliters, and then this is very important, long-term follow-up with ultrasound. And about long-term follow-up, how long should we follow these patients? We perform as a routine the ultrasound at 1 month and 3 and 6 months, depending on the first ultrasound, and then every year. But I have to underline that 2 of our cases showed obstruction after 7 years. So maybe we have to perform ultrasound every year for, I don't know, until the puberty, probably. And now I want to make some comments on endoscopic treatment of VUR in complex cases. This is endoscopic treatment in double system. The insertion of the needle can be under one or under both the meatus, but it depends on the distance between the 2 meatuses. And also a complex case is considered the endoscopic treatment in VESICOURETERAL reflux in the previously reimplanted ureters. And yeah, actually there are 2 different situations. One is the failure of ureteral reimplant in primary reflux, and in these cases, success is quite high. It's 95% of cases. And another situation is VUR after renal transplant. And in this instance, we found a success in 50% of the cases. And this is the technique. We prefer to insert a ureteral catheter inside the ureter to get a better exposure of the meatus. And then the injection can be performed not just near the meatus, but also along the tunnel. And this is endoscopic treatment in renal transplant. We put the catheter as well, but the injection is not so easy, and it's an explanation of the success rate, because you know, in renal transplant, usually the ureter is implanted with a Leach-Gregoire technique that is not favorable for endoscopic treatment in case of reflux. And finally, I want just to mention the possibility to treat reflux in neurogenic bladder. It's not always possible because, you know, sometimes in a neurogenic bladder, there are a lot of diverticular and you can't see the meatus. But when it's feasible, it's a good idea to perform both Bantris and Botox injection at the same time. Thank you.
Grazie mille. Without further ado, I'll bring on Professor Chertin. And one of the questions that we had been asked, I think you nicely answered, Nicola, on when do we do open surgery, or at least reimplant. Professor Chertin, who's the chair of pediatric urology at the Shari Zedek Hospital in Jerusalem, has become an expert in laparoscopic and robotic-assisted reimplantation, and we'll turn the tables a little bit from injection techniques to when and how do we use these sort of more invasive but still less than open surgical alternatives. So go ahead, Professor Chertin.
Marty, thank you very much, and thank you for Promedon again for their generosity and the possibility to share our experience in those times. We are not able to meet personally, at least we can use the technology in order to share our experience. It was a privilege for me to share this, this virtual podium with my friend, mentor and friend, Prem Puri, and my very good friend, Nicola. It's pity, Nicola, just a year ago, been working in Rome together for 1 month before this pandemic. Hopefully we'll be able to do it again in the future. So without further ado, I would like to share with you our experience with the robotic assisted surgery. And today my task will be very difficult since I'm going to talk about a robotic assisted laparoscopic reimplantation, which there is no consensus among pediatric urologists or pediatric surgeons regarding cost effectiveness of this procedure, not only the cost effectiveness, but also the efficacy in the clinical practice, and also the versatility of this procedure regarding the approach for refluxing or obstructive uropathy in children. So today we all know that only robotic assisted pyeloplasty is recognized as safe and efficient with excellent outcome compared to the open or laparoscopic surgery. We've been published recently a couple of papers further supporting this hypothesis. And in our service today, robotic assisted laparoscopic pyeloplasty done exclusively in all children with UPJ obstruction, regardless the weight and the age of those children. So we also published the data supporting that those surgeons with the previous vast experience in open surgery and the laparoscopic one are able to reach the level of expertise very quickly, and there is no difference between the outcome in the first cases of the robotic surgery compared with the open or laparoscopic one. So why we should extend our interest in robotic surgery? First of all, I think we can bring the better care for our children, for the children who are going to operate. And the second one, the majority of the residents who are seeking for the fellowship program, for the residence program, are very interested in the robotic surgery. And robotic surgery today is among the first top subspecialty where the fellow or the residents are interested to be trained. So we have no choice. In order to rise the new generation of the pediatric urologists, pediatric surgeons, we have to extend our skills and we have to transfer our expertise and our experience also with regards to the robotic surgery. So why we have to seek a new minimal invasive technique? Prem and Nicola just very nicely demonstrated the efficacy of endoscopic correction over the years. It is an outpatient procedure. It's feasible in all of degree of the VUR. It's also very effective in the complex cases. The rate of the VUR cessation is close to the open surgery. However, there is a variability between the centers of the excellence. And we do see from the papers that sometimes the outcome of the endoscopic correction of reflux is different from the one center to another one. It's just the one slide showing our experience with the Vantis ejection in the multi-center study where 17 pediatric urologists and pediatric surgeons took part. And you can see we were able to treat grade 3 in almost 100% of success. Also the grade 5, we achieved almost 70% of success with 2 injections. So it's definitely a test of time, not only in the short term, but also in the long term, follow-up. However, we are not able to brush aside the complications of endoscopic surgery, and the main complications is the obstruction, which can develop. So the obstruction rate we can see the obstruction following endoscopic correction of high grade of reflux. Also, when we deal with the obstructive and refluxing megaureter, those patients who've been treated with inflamed bladder mucosa. So this is the paper that Nicola already presented. Nicola, I would like to take the opportunity and just to thank you for to be our very valuable partner in our recent research. It's not that the Chertin did this study, we did both institution and actually contributed to the outcome of this study. And I think today we have kind of view what kind of patients we can select for the endoscopic correction, and those patients will able to refer for the open or laparoscopic or robotic surgery straight away from the beginning. Again, what we found over the years when we have to deal with the obstructive ureter following endoscopic correction, extravesical approach is preferable, and you're able to approach the obstructive ureter from behind the bladder, avoid the obstructive component, and the surgery is much easier. So when keeping in mind when extravesical approach is preferable to deal with the obstructive ureter, we turned out our attention to the way how we can deal with the extravesical reimplantation. So extravesical reimplantation as an approach is pretty old. Leach and Gregoire published the date in 1977. Afterward, the Mark Zients in States popularized this approach. Also published a couple of technical refreshments which were able to increase the outcome of the reflux cessation. It can be feasible in all grades of reflux. You have to be very cautious when you deal with the reflux and obstructive ureter, since you are not detect the blood, not perform dismembered reimplantation and not detect the blood, the ureter from the bladder during this procedure. And also the operating space can play a role when you're doing this procedure. Sometimes it can make obstacles, the technical obstacles before the surgeon while doing this procedure. So trying to utilize and make this procedure much more friendly for the surgeon, Greg Peterson in 2004 published the first report on extravesical robotic assisted reimplantation. However, the success rate was about 88%. The reported success rate in the following paper range between 72 to 98. However, we are not able to brush aside the complication rate, which was published in those papers, and sometimes the complication rate was high, up to the 15–20%. The majority of the complications were related to the tackling the ureter during this procedure, and the investigators reported increased leak from the bladder, from the ureter, and also the ureteric injury during this procedure. So in 2018, was published the first prospective study from the 8 academic centers in the United States on the robotic assisted laparoscopic extravesical ureteral implantation, RALUL technique. And they published that the outcome of this surgery was similar to the open reimplantation. Also, they stated that the complication rate wasn't different from the open surgery. However, this paper was lack of the long-term follow-up and also the absence of the radiological follow-up in the big subset of the patients. So we have to take very cautious the outcome of this study. Another study published in the World Journal of Urology in the same year showed how the meta-analysis compared the robotic assisted laparoscopic reimplantation versus open reimplantation. It was very interesting to see that although there is no difference was found in an estimated blood loss during the surgery, success rate and the complication overall, while the researchers performed the subgroup analysis, it was very high rate of the short postoperative complications in the robotic surgery, and the majority of those complications again was related to the leak from the bladder or very short complications related to the tackling of the ureter during this procedure. So although this meta-analysis showed there is no difference between two techniques, we have to be very cautious while employing this technique to our patients in the wide clinical practice. So this is the last paper what I would like to share with you. It's the meta-analysis published in the Pediatric Surgery International in the last year. Compares the data between robotic assisted and pure classical laparoscopic surgery. It was very interesting to see that the majority of the patients nowadays undergo through robotic surgery, and there is no increase in the number of the patients who undergo classical laparoscopic approach. However, this meta-analysis showed that still the outcome of the laparoscopic surgery is a bit higher in terms of the success rate. The complications rate was a bit higher in the robotic surgery group. And again, however, the number of the patients who've been treated with grade 5 of reflux is significantly higher in robotic surgery. So the surgeons who perform the robotic surgery feel much more comfortable to deal with the high grade of reflux, employing and utilizing a robotic approach. So how we can reach the level of the expertise and how we can provide to our patients the very good outcome utilizing robot approach. So today I'm going to share with you our experience, and I would like to iron out some technical points which you can use in your practice in order to achieve a good outcome with the minimal complications rate. So this is the this is the setup of our operation room. You can see the patients. We used to put the patient in the lithotomy position. In the lithotomy position, put them on this pink pad, which actually avoid the sliding of the patient during the procedure. We utilize some slide Trendelenburg position, and this is the setup of the room, which allow you to dock the robot in between the legs of the patient, and it's plenty of space to fill out the bladder and plenty of space for the scribing and rotating nurse to help you out during the procedure. So we work very close collaboration in our anesthesiology group. We published a couple of papers of utilizing a combined anesthesia with low dose caudal MO and recently ultrasound guided quadratus lumborum block to provide to our patients painless post-operative period. You have to keep in mind there is no access to the patient during the robotic surgery while the robot is docked. So you have to use long inhalation tubes. We used to put 2 IV lines in order to avoid any problems during the procedure. You have to keep in mind we are not able to move the operating table after the docking. So all setup should be done prior to the docking. And again, we would like to use the marking infiltration prefascial space upon trocar session in order to avoid any pain after the procedure. And this allows us to discharge our patient the following day and even the day of surgery, evening light, in order to and also provide them painless post-operative period. So I would like to share with you a couple of technical points which have been pointed out, but Monar Gundeti from Chicago, and he shared with me his slides. This is the slide you can show. As you know, as all of us know, we always very careful to apply extravesical approach, especially in bilateral cases, in order to avoid post-operative urinary retention. So while dealing with the ureter, trying to release the ureter upon the UVJ, and also afterward to develop the submucosal tunnel, you have to be very careful not to tackle this space where the dorsomedial plexus is based. So if you try to avoid this space, where I show you on this slide, you can avoid in the majority of the cases post-operative urinary retention. And so you patients will be able to go home with the same day and the following day. Again, in this place, you have to use only cold cutting technique without using any diathermia. Again, in order to achieve a very high ratio of the reflux cessation and to try to get the same results like during the open surgery, you have to create very nice and very long submucosal tunnel. Usually we do the tunnel between 5 and 4 centimeters. I do use the same anchoring stitch like Gundeti showed in his slides in order to avoid sliding of the ureter from the place of the tunnel, and close the tunnel either using interrupted or running stitch. So we found this technique is pretty comfortable while using this technique, utilizing this technique for the primary reflux. However, for the obstructed megaureter or for the obstructive refluxing megaureter, when you have to cut the ureter of the bladder and to perform dismembered ureteral implantation, we found this technique not very suitable, and we developed our technique, which we called Radicure technique. We published this data with the collaboration with a friend of mine, Dr. Neyman from Wawa Hospital in Jerusalem. It's a short-term assessment. We call, as I told you before, this technique is Radicure, and I'll show you a couple of technical points of this technique. So this is the children with obstructive reflux and megaureter, grade 5 of reflux. You can see we tackle very nicely the ureter from on the left side, avoiding the injury to the vas deferens. We tied the ureter since the kid has a ureteric reflux. The robotic platform XI or SI is allow us to create very nice submucosal tunnel without injuring the mucosa. You can see it very nicely. So by using the robotic platform, you can perform intracorporeal tailoring of the ureter without any problem. It's no reason and no need to take ureter out of the belly. You can see we perform this procedure without using the diathermia in order to avoid any terminal injury to the ureter. We do use VLAC stitches in order to close the ureter, and of course performing the reimplantation on the double J stent, which we can actually easily put during the procedure utilizing the robotic device. Again, the robot platform SI or XI is allow us to use the intercorporeal suturing without any problem, and you can afterward you can close the detruser also using the VLOC technique. Again, in our refreshment in this technique, you can see here we put the anchoring stitch at the end of the tunnel in order to avoid the sliding of the ureter from the tunnel, and also to avoid any kinking of the ureter and the obstruction after the procedure. Again, VLOC technique, VLOC stitch is very handle and very nice to use while closing the detruser, and also shortage the time of the operation and allow us the versatility and allow us to finish this procedure in a very short period of time. So you can use this procedure also for the small kids. In the complicated cases, this is the case of the kid who's 2 years old, who got, you can see, bilateral ureteric ureterostomy as a result of a PUV and a acute renal failure, which he developed straight away after the delivery. We performed the bilateral ureteral implantation, and afterward we used the robotic technique in order to take down ureterostomy and perform reimplantation on both ureters. We use 3 trocars of the robot and 1 trocar as assistant port. You can use IO 10 or 5 millimeter. You can see here, this is the XI platform. We use the minimal dissector techniques, and you can see we use the stitches in order to hold the bladder to the abdominal wall. Again, the robotic vision allow us to create a very nice 6 centimeter tunnel and to open and to dissect the detruser of the mucosa very nicely. We do perform, you can see it's very easy to perform the reimplantation, intracorporeal stitching again with the robot perform very nice. And here I would like to put your attention this stitch that we can develop over the years. You can see we use the stitch which goes from the detruser, tackling the ureter, closing to the detruser on our side. Actually, this is the anchoring stitch will allow us to avoid the sliding from the ureter from the place of the reimplantation. And then UVJ. Again, the stitch here on the end of the tunnel, which anchor the ureter and avoiding the sliding of the ureter from the place of the reimplantation. And again, it's enough place to put both ureter at the same submucosal tunnel. The intercorporeal suturing with the robot platform is very nice. And again, here we close the detruser with the utilizing the VLOC. After the procedure, the bladder is filled out with the saline. There is no kinking and there is no leakage, and the patient goes home on the following day after the surgery. So there are 2 technical points which we'd like to raise your attention. Again, the robotic platform utilizing microdissector and the scissors allow us to perform very nice submucosal tunnel, tackling of the detruser of the mucosa without injuring the mucosa, so you can easily put the 1 or 2 ureters at the same tunnel. You have to use this anchoring stitch, which will allow us to avoid the sliding of the ureter from the tunnel, and also to avoid any kinking of the ureter of the tunnel. And again, use the VLOC in order to close the detruser. It shortens the time of the operation, and also it will make intracorporeal suturing is very easy. So this is our own series, what we did, all of the 3 years of the follow-up, those children with this, at least with the 6 months of the follow-up. The majority of our patients with the reflux and obstructive megaureter or primary obstruction, 1 patient after the failed endoscopic correction. We did use this technique for 8 patients with a obstruction of the ureter following bulking agents, are different one from ventris to ventris coaptite and reflux. And you can see the weight of our patients is different. Also the age we used to this technique, also the age of 1.5 years. So 8 patients required intracorporeal tapering, and as I showed you before, it can be done very easily utilizing a robotic platform. We did 3 bilateral cases. We have 7 takedown ureterostomy subsequent to implantation, and we performed 2 common shift implantation. It can be done very easily again. So we have one reflux recurrence after obstructive megaureter, reflux grade 2, and we treated this patient with a sting technique. As Nicola showed in his slides, you can, if you don't feel comfortable to inject the needle, you can put ureteric catheter straight away to the ureteric orifice, and afterwards utilize the ureteric catheter as a handling in order to put the needle in the precise place for endoscopic correction. So what are our home messages? If any benefits for robotic implantation in our surgical armamentarium, you can see there is a decrease of the number of the ureteric implantation over the years in the United States. However, at the same time, the number of minimal invasive surgery was on rise. And again, the majority of those cases performed robotically. So if I don't like to talk in my lectures about the economical benefits, since all of us are working in very different economical systems, and our reimbursement for the surgery is different from country to country, and we have to tailor our cases to our medical system. It's very hard to copy and paste the medical system which exists in the United States to the European country or in Israel, for example. But however, you can see still the cost of the operating room for the robotic surgery is a bit higher than the open surgery. However, I think with the increase and the improvement of our learning curve and our expertise, we're able to achieve the operating time the same as during open surgery. So today, for example, when doing the pyeloplasty in kids, regardless of their age, we are able to achieve the same. We are actually waste the same operating time like we did during open surgery. I don't think in very near future it will be the same situation also with the robotic reimplantation. And I think the operating time won't be an issue very soon. So since Marty is our moderator, I took the liberty and to put a very recent paper from the Canadian health system showing that also in the Canadian medical system, which is very similar to the European one, there is a place for the robotic surgery in terms of the feasibility and also cost effectiveness. So what is the message we'd like to deliver for you? There is a place for the robotic surgery, robotic reimplantation in surgical armamentarium. It shouldn't be replacement for other methods. It's not a first choice in our place, and still we have a lot of patients who undergo for endoscopic correction. But again, if you make a very nice selection, a very proper selection of your patients, you have a different surgical tools in your hands, and you're able to provide the best care of your patients while you're able to select your patients for endoscopic correction, for open surgery, or for the laparoscopic robotic one. It shouldn't be replacement for another methods. It shouldn't be definitely your first robotic surgery. You should keep in mind the surgical steps. It will allow you versatility. I think you are able to teach this technique for not only for the surgeon with the big and the previous experience in the open or laparoscopic surgery, also for our residents, and will short our learning curve. It should be and might be for everyone. And again, guys, I would like to thank the Promedon for their generosity and the possibility to share our experience. I wish for everyone and for your family, be healthy and stay healthy in this year. Hopefully the vaccination will work out and will able in the near future to meet personally and to share our experience. Thank you very much, Martin.
That was really fantastic, Boris. And I loved the way all of your presentations overlapped and were able to provide such continuity. We've had some questions that I've tried to answer along the way, and I'd like to pose some of them to you as panelists, as well as some as I've created myself. Firstly, Prem, you're the guru, you're the dean of injection therapy with more than 4 decades of experience. How would you tell our audience who from all over the world, different cultures, different, as Boris said, different socioeconomic groups and medical systems, how do you decide what to inject? Is there a difference between the compounds that are available for injection?
Marty, I have only experience of Teflon until 1990, and since 91, I've been injecting deflux. I don't have experience of Ventris, so I'm not going to comment on that. But it all depends upon the tissue augmenting which is available to you. But I've had very good results. As I said in the beginning, the most important aspect is the placement of the needle, and I make the injection superficially and just under the mucosa. You need less. I'm surprised to see some of the obstructions mentioned by Nicola as well as Boris, because Nicola mentioned a case where it was 7 years later. It would I would have loved to see, because he also mentioned that they do an ultrasound every year. I would have loved to see the serial ultrasounds on those patients, because coming to the obstructions, we published a paper, a meta-analysis last year with 25 publications. There were only 96 obstructions. And so obstruction is less than 1% of patients.
Well, why don't we see if Nicola might answer that then, and Boris, you as well, because you had 8 procedures that you intervened at, with obstruction robotically. So Nicola, why don't you go first? You're muted. Nicola, you're muted. So are you, Boris, just to let you know.
Big Brother watching, huh?
Yeah, Nicola, you're still muted.
Nicola, you muted.
Yeah, okay. Sorry. I mean, obstruction is a very rare complication. It's about 1%. So, but it's difficult to say if it's the pre-existing dilation of the ureter, so the ureter is hypotonic, or maybe is the amount of material, because in a grade 5 you tend to use more material, or if it's the technique, because in grade 5 you use intraureteral. So it's not easy to understand what exactly is, okay? But I mean, we made some modification over the years. One was the metal needle instead of the flexible one. And according to my experience, this has contributed to a significant improvement of success rate. It depends on experience. My experience is different.
Nicola,
yeah?
My question to you was, the 2 patients that you mentioned who were found to have obstruction 7 years later. I mean, you do an ultrasound every year. But these 2 patients, did they lost to follow up, or
No.
you?
No. Okay. After 4 or 5 years, we saw some dilation of the ureter, but less than 10 millimeters. I mean, 10 millimeters for me is the limit. And after the 7th year, we saw a significant dilation of the ureter, and we performed rhinoscintigraphy, and they had a loss of function as well. So the ultrasound until year 4 or 5 was okay. But I can't say what it was. And they were both were deflux cases. So maybe Ibantis doesn't matter.
So we don't know. Short follow-up. What about you, Boris? You had your 8 cases.
Yeah. First of all, Marty, I think it's I have to repeat what Warren Snodgrass told once. When you follow your patients prospectively and you tackle your data prospectively, sometimes you have a different outcome and different conclusions. So when we started the VUR study almost 10 years ago, we followed all of our patients prospectively. It's a good reason to say it's a big gratitude, and my big thanks to my partners who were able to tackle those patients prospectively. And what we found that I agree with Prem that the majority of those patients, at least in our experience, they started to develop hydronephrosis 3-4 months after the surgery. But we decided to operate on them a little bit later when there were the clear evidence of the obstruction. So it's not that we just, the hydronephrosis just pop out in suddenly 3-4 years afterward. It was a development of hydronephrosis straight away after the injection. We never seen in our practice, at least, the sudden obstruction 4 or 5 years, and this is the reason that we published this paper that Nicola mentioned with the Russian groups from Moscow, showing that all cases of the obstruction developed over the 2 years after the surgery, and the first evidence of the obstruction was on the first ultrasound after the endoscopic correction. Again, I agree with Nicola that you have to be very careful when you're dealing with the high grade of reflux. With the majority of those patients that the John Duckett with Barry Baskin taught us years ago, they have kind of obstructive reflux and ureter. And when you do that, even if you don't see the obstructive component, it can be, it can be developed straight away after the curation of the reflux. So you cure the reflux, but you increase the resistance of the UVJ, and as a result of it, the obstruction just increases. So for this reason today, we evaluate very, very carefully all images of the VCUG, especially post-voiding images. If you see even small, the light evidence, the light suspicious of the obstruction in the VJ, we refer those patients for a robotic surgery. So,
Nicola, you've had experience with multiple injecting materials. Some are more difficult to inject from a physical point of view. Does that mean you can translate your experience with, let's say, Polytep or deflux or chondrocytes, whatever you've used, to Vantris? Is it the same, since Vantris is the new kid on the block?
Yes, Vantris and deflux are similar. They are very easy to inject, and it's not the same for macroplastic or Polytep. They need a special device, a sort of gun, to be injected. This is the only difference, but there is no difference with Vantris. You need, of course, a Luer lock syringe that is in the kit. Okay, you shouldn't try to inject with other type of syringes, but it's quite easy. And I mean, if it's easy, you are more precise. You can put the material exactly in the right place. If it's difficult and you use the gun, you can be wrong. You can't find the right plane.
So a couple of questions, and again, this relates to the whole group. In patients with high-grade reflux, Prem said even in infants and young kids less than 6 months of age, he would recommend injection therapy. Do both of you agree? And secondarily, if you, Prem also made the comment that with his success and experience, that all patients probably, and again, Prem, I don't want to misquote you, should have a first attempt at injection therapy before going to something like open or robotic or laparoscopic interventions, more invasive procedures. So first comment on the ages and the type that you would use, and should we always try injection and reserve other techniques, more invasive techniques, only for failures? Did I quote you properly?
Yeah, Marty, yes, if I could comment on this before. Firstly, all of you would agree that the reimplantation is certainly open implantation is not an easy operation in a 6 months or a 9 months old baby. So I said for infants with high grade reflux, as well as older over 1 year of age who have grade 4 or 5, at least even those who are like the open surgery or robotic surgery, give the child a chance to one chance to see if you can stop the reflux which in my experience, you can stop it at least 7 in 10 patients, in about 70% of patients, even with grade 5 reflux.
Boris?
And
Okay, Boris, Nicola, what are your thoughts?
If you just first I agree with Prem. I mean, Prem, listen, you taught me how to do it, so I can't disagree with you. But anyway, I think it's a good technique if you have to deal with this subset. I mean, we don't need to deal. It's not a big group of patients, but we also published a paper a couple of years ago. Even if you don't cure the reflux, the high-grade reflux involves in infants, but you are able to downgrade, for example, grade 5-4 to grade 2-3. In 40% of those patients, the reflux will disappear completely in the follow-up period, and also you avoid a febrile UTI in those group of patients. So it's a very nice option to deal at least primarily with those patients. I agree with Prem to do the reimplantation either openly or robotically in the 6 months of infant, 6 month infant. It's a very big technical challenge.
Okay, our policy is to perform endoscopic treatment at 6 months, starting from 6 months, and never open surgery before 1 year. Sometimes we wait because the ureter is bent, is dilated. So maybe we perform an endoscopic treatment at maybe 18 months. So we wait. It's not a rule to perform open surgery at 1 year, even if there are not indication for endoscopic treatment.
Okay. So one of the things we haven't talked about, which is a huge indication oftentimes for leading us to intervention, is voiding dysfunction or bowel bladder dysfunction. Do you, and our friends from Sweden have suggested, from Uppsala have suggested that perhaps we might improve bowel bladder dysfunction by intervening, thinking that the reflux may be causing a yo-yo effect. Do you think we can improve voiding dysfunction, or do you treat voiding dysfunction first? So again, open question to the panel.
Marty, like Lackner group, we also found that many of these patients, you are able to get rid of the bowel bladder dysfunction. Having said that, when we did the study when we looked at the incidence of febrile urinary tract infections in a very large and long-term follow-up, following patients from 6 months to 9 years, and we found this 73 patients who had recurrent febrile urinary tract infection. And when we did that VCU, there were only a handful of patients who had reflux, but the vast majority, the problem was bowel bladder dysfunction. And in those patients, you need to treat BBD.
Nicola, Boris?
Yes, of course, we treat dysfunction first, but we keep in mind that sometimes at least the bladder dysfunction can be secondary to reflux. So sometimes we treat at the same time the dysfunction and we perform endoscopic treatment, maybe after a few months.
I agree with you. I agree. I think today the approach to the kit with the VUR and the BBD, it should be very, very flexible. It's not like before we been taught you have to treat BBD upon the endoscopic correction, see what's going on. In some cases, maybe the reflux will disappear. I agree actually with the conclusions and of the Sweden group. There is a yo mechanism, this subgroup of patients. So if you have to start with the treatment of the BBD, you have to get your patients with very, very nice compliance. So we are compliant and we are able to follow all of your rules. It should include not only therapeutic, not only pharmaceutical treatment, but also the pharmacological treatment, also urotherapy, and you can proceed with the endoscopic correction of reflux. While I think the outcome of your complex treatment will be much higher.
So Nicola, you've also been a proponent of Botox injections, I know, for neurogenic bladder. Might this be an opportunity to use dual therapy for non-neurogenic situations for the severe voiding dysfunction patients, where you
Yes,
care
yes.
the reflux and the bladder with Botox and one of the injectables.
Yeah, exactly. Exactly.
Okay, so we don't have much time left, and I'm going to just make one statement. And again, you guys can interject and follow me, but Nicola showed the importance of looking at VCUGs. And I just want to reiterate that I think one of the biggest problems that we've had with injection therapy and obstruction that we've talked about has been missing those likely primary obstructive megaureters that we take from a very partial obstruction where renal function hasn't been impaired, and we convert them to a more severe obstruction. And my rule of thumb has been measure twice, cut once. That's when we used to cut more than inject, and which meant to me, not only would I look at the VCUG in great detail before I ever suggested surgery, but make sure again in the operating room that what I see endoscopically correlates with the VCUG. So if I don't see a gaping ureteral orifice and it's a quote grade 5 reflux, I'm not going to inject that person. That worries me. Nicola, Boris, Prem.
Yeah.
Marty, I would 100% agree with you in this, because if you don't see a wide golf hole orifice, you know, and that's why I like the indications of robotic surgery of Boris. You know, his main indications for robotic surgery were obstructed megaureter and refluxing obstructive megaureter. With again, Nicola also showed some of those examples. That's an absolute contraindication to any type of endoscopic treatment.
Okay.
So I think
sorry.
we're at our time limit. Is that right, Alejandro?
Yes, I think we would have some space for a couple of questions more. No problem with that.
Okay. Do any of the panelists want to make any more comments?
I've been asked one question here, if the robotic surgery should be the preferable option for failed endoscopic correction. First of all, as I told before, we found that if you have the obstruction following a endoscopic correction, it's much easier to deal with the ureter behind the bladder, not to get inside of the bladder. So if you have the robotic system, it's of course it makes your life much easier to deal with the ureter behind the bladder, just to cut off and to perform extravesical implantation. But if you you do a open surgery, do it extravesically, it's much better to just to tackle the ureter from behind the bladder, not to get inside of the bladder, try to dissect the ureter of the bladder from there. And again, it's up to the possibility. I think we still endoscopic correction should be the first option in your hands. And afterward, of course, it's a good selection of the patient. You can deal with the right selection and right to apply the right kind of treatment to your patients.
So,
Marty, it's a very important message to convey to the participants, and that the obstruction following endoscopic treatment is extremely rare. Let's remember, it's very rare. You know, as we have shown in our meta-analysis and also from my experience. And I mean, I remember once when we just started this procedure, and Duckett said he's not going to do it because he had an obstruction. And when we found he had injected 3 mil of Teflon into the under the ureter, so naturally it was going to be obstructed.
Well, it's funny, you know, John was very instrumental in bringing our Swedish compatriots and Nicola and Paulo to America to really teach us how to do it here. And then, of course, many of us came to visit you to learn the technique as a group, which was a fantastic learning experience because we learned from you, but with others. It was a great way of learning how to do things. And it's great to have a wonderful global participation like this where we can interact with colleagues, have questions given to us, but nothing beats that in-person opportunity to interact and learn with and from one another. So I'd like to thank again all of you as panelists for participating. Great presentations, wonderful answers to the questions posed by the audience. And again, I'd like to thank Promadon and Alejandro for being such gracious sponsors and supporting this endeavor and keeping us on time. Any closing remarks from the company, Alejandro, that you want to make?
Of course, Martin, thank you so much. It was a great honor having this space with you, with the speakers and the presentations. They were awesome. And with you, Martin, we didn't have any experience in the past with you as moderator, but I think you do have a lot of experience. It's been great having you on board. And I think all the audience enjoyed. And in the name of Promadon, again, a big honor having you in this space. I hope we can do it again, and why not to do it in present some part of the world and meet each other. Okay, thank you so much to everyone.
Fantastic, thank you. Thank you to all of you who took the time to attend and participate, and especially for asking questions.
Marty, good to see you.
And likewise, it's wonderful. I hope that I come to visit soon.
Yeah, soon.
You know, I hope that we can make it to Portugal.
Yeah.
Portugal, yes.
I'm not so
Far away,
sure.
go.
I'm not so sure it's, you know, for us because of quarantine issues and everything, whether we'll be able to do it.
But hopefully for everyone, we'll be able to meet in person very soon.
Yeah, yeah.
Yeah, Marty, you might be able to combine with UPSA because they're both close to each other. UPSA is in Athens this year.
Well, invite me, Prem. You know me. I love coming to UPSA with you.
Yeah, because Promadon is sponsoring a symposium there. So hopefully,
UPSA will be in Tel Aviv this year, no?
No, Tel Aviv 2022.
22, okay.
Yeah. 21.
Well,
Let me say something in Italian. Grazie e arrivederci a tutti.
Grazie mille.
Ci vediamo presto a Roma.
Okay, and to those from South America and Mexico, where we had our largest contingent, gracias.
yes, we did have a lot from Mexico.
Yeah.
Okay, thank you to all. Gracias, grazie. Ciao, ciao.
Yeah, thank you.
Buonanotte.
And shalom aleichem and Shabbat shalom.
Shabbat shalom.
Bye.
Bye.